Good morning, Dr. Stein and all other colleagues. So today I'm going to share with you a case that I've seen during my time in Dr. Bernard's clinic. So it's a case of steroid responsive encephalopathy associated with autoimmune thyroiditis. So the patient is a 32-year-old lady who has got good past health. She presented in July of 2019 for tremors in his hands, bilateral hands, and a loss of dexterity on bilateral hands upon awakening. And over the day, she developed bilateral upper and lower limbs weakness. And at the end of the day, she also realized that she's got slurred speech. So she presented herself to the emergency department. And we do not have the physical examination results at the ED, but we know that the MRI and CT is normal. They are remarkable. And somehow the patient was discharged 3 days later. And 2 weeks later, the patient presented herself at Dr. Bernard's clinic. She was alert, a febrile, and her blood pressure is normal. She has to walk with support, and her speech is intelligible. There was weakness of all her limbs, and there were tremors in her bilateral hands. The tremor is slow, around 3 to 5 hertz, and they're high amplitude. You can see it's noticeable even if you're sitting like across the room, and it is an intentional tremor. So upon questioning, she also reports symptoms of dysmetria, bradykinesia, movement in coordination, and to have clumsy balance. There are also mild tingling sensations in her hands, but otherwise there are no other sensory changes. She also complained of blurred vision, tunnel vision, nystagmus of both eyes several times a day. So at this juncture, the symptoms were the most severe. So we did, Dr. Bernard did a physical examination on her. The muscle tone is normal, but there was diminished power in all of her limbs. So the power is 4 out of 5. There's no loss of pinprick or proprioceptive sensation. And on examination of her cerebellar function, the finger nose test is abnormal. The heel to shin test is also abnormal. And there were intentional tremors and also dysmetria and also dysdiadochokinesia. Cokinesia. And she was unsteady when she was in a standing position. And the Roomba's test is negative. Okay, so her clinical picture is cerebellar ataxia. And considering that it develops over 2 weeks in 1 day, and also it continued to progress, worsen gradually over the next 2 weeks, it's a case of encephalopathy. We treat it as a case of encephalopathy. And the list of differential diagnoses can be classified into what we're seeing on the screen. So we are thinking of it may be a vascular cause, such as stroke or vasculitis. It may also be due to infections, maybe due to toxins such as alcohol, drugs, and carbon monoxide intoxication. It may also be due to autoimmune causes, such as an example would be limbic or NMDA-R encephalopathy. It may also be due to malignancy, such as CNS lymphoma or metastasis. It may also be due to metabolic causes, such as mitochondrial cytopathies. It may also be due to inflammatory diseases, such as multiple sclerosis, NMO. Also, we have to rule out neurodegeneration diseases, such as Creutzfeldt-Jakob disease, Alzheimer's disease, frontotemporal dementia, and dementia with Lewy bodies. So actually, after taking a thorough history, we can rule out a number of these differential diagnoses. We can rule out stroke, because it's already been 2 weeks, so it's very unlikely because and also we have evidence of a negative CT and MRI scan back in the ED. It is also unlikely to be due to toxins. The patient that reports that she has not been drinking alcohol, she is not taking any drugs, and also it's in the hospital. Carbon monoxide intoxication will be ruled out. Vasculitis is also unlikely because considering she does not she does not complain of any symptoms suggestive of vasculitis. Inflammation is also unlikely, but for vasculitis and to completely rule out vasculitis and inflammation and inflammatory diseases, we'll need to work up on them. Nevertheless, neurodegenerative causes such as Alzheimer's disease, frontotemporal dementia, and dementia associated with Lewy bodies are also very unlikely, considering the patient's age and considering that she's not complaining of any cognitive disturbances, nor any psychiatric disturbances. So what we did is a lumbar puncture, an EEG, and an MRI brain. So the results of the lumbar puncture is all normal. The opening pressure is not elevated. The appearance of the CSF is clear. The range of proteins and glucose and lactate are normal, and there's no white blood cells or red blood cells seen. And even when you after doing a gram stain culture, there's no organisms found. So this is the EEG of the patient. We can see that there's some alpha and beta background waves. So it is again normal. And again, the MRI brain done 2 weeks after the normal MRI we got from the ED is also normal. So these 3 normal results actually help us to rule out further more differentials. Infections are unlikely, although we'll do more work up later on to confirm that. Malignancy and metastasis, we're particularly talking about CNS lymphoma. It's unlikely because on the MRI, there's no any structural lesion seen. Metabolic, mitochondrial metabolic causes. Mitochondrial cytopathy is unlikely because the lactate is normal in CSF, although we may also consider checking the lactate level in blood to further rule it out. So we talked about infections. So the most common cause of encephalopathy is thyroid encephalitis, and the most common organism found is HSV. So we have done a PCR test of HSV as well as VZV, Epstein-Barr virus, cytomegalovirus, as well as West Nile virus. So other common causes of encephalitis include syphilis and also Lyme, especially in the US, considering that the patient leads an active lifestyle and she always goes hiking. So we also did a Lyme serology. Both results all the results came back to be negative. Of note, we may want to check if there's any cryptococcus, and also especially in areas where tuberculosis is commonly found, we may also want to check tuberculosis in immunocompromised patients. So a differential diagnosis also we have to exclude is the Creutzfeldt-Jakob disease. So this is the diagnostic criteria for CJD, and as we can see, the patient actually does not satisfy. At most, we can only categorize the patient into having a possible CJD. But that's also very unlikely because she's not presenting of any memory impairment. And as the patient is a young female, we're also considering if that could be due to hematological diseases. So we took her bloods and checked for any acute phase reactants such as CRP and ESR. Both are not raised. We also looked into the blood count, which is normal. Well, we looked into the anti-nuclear antibody and the P anchor and C anchor. They are all negative. So the chance of the patient having lupus or having a vasculitis is very low. Okay, so given given that we have exhausted most differential diagnosis, so what should we do next? So we're looking into autoimmune encephalitis. But autoimmune encephalitis is a very complicated disease entity because they are, the brain is prone to immunological attack by many antibodies. So we can see here, I've listed these antibodies into I've categorized them into 3 groups. Antibodies that react to the self-service antigens in the brain, into the intracellular synaptic proteins in the brain, and also the intracellular antigens in the brain. So these are the 3 main groups. So the way to diagnose autoimmune encephalitis, many people will straight off do to check if there's any antibodies are present in the patient. But this is actually not a desirable thing to do because first off, we cannot check all of these antibodies. It would be very expensive, and also it takes a very long time for the results to come back. So to diagnose autoimmune encephalitis, we actually got a diagnostic criteria. So it is mainly based on the clinical symptoms. In the clinical symptoms is classically said to be a subacute onset deficit of the working memory, and also subacute onset of seizures, and also some psychiatric symptoms. Interestingly, our patient do not have any of these symptoms, do not present with any of these symptoms. Also, the second criteria would be bilateral brain abnormality, MRI abnormalities on the MRI, especially in the medial temporal lobes. Again, our patient does not satisfy this criteria. And the third criteria is either one of CSF pleocytosis or EG with epileptic or slow wave activity involving the temporal lobes. Again, our patient do not satisfy this criteria. The only criteria that our patient satisfy is that we have excluded all the alternative causes. So, what are we going to do next? So on further questioning of the patient's history, we found out that the patient has got a family history of thyroid disease. So she's got one of her maternal aunt got Graves' disease, and also several members from the mother's from the mother's side of family also got goiter. And also the patient is on Synthroid, which is the commercial name for levothyroxine since 2014, because she was infertile at that time. But since then, she was able to conceive, but she's still taking the Synthroid afterwards. She's still taking it right now. So we did a physical examination of the thyroid region. So the patient is clinically euthyroid, but we can feel that there are around 2 to 3 centimeter lumps on both sides of the thyroid. So we checked the thyroid function test. We did a thyroid function test, and which came back to be normal. TSH, T4, and T3 were all within normal limits. We also checked for thyroid antibodies, and the only thyroid antibody that was raised was the TPO antibody, and it was the titer level was 158, which is very high compared to the normal, which is usually under 30. So we also recommended the patient to get thyroid biopsy, and the biopsy results came back to be suggestive of Hashimoto's thyroiditis. Okay, so with these clinical information in mind, we considered the diagnosis of steroid responsive encephalopathy associated with autoimmune thyroiditis, which is also known as Hashimoto's encephalopathy. Sorry, this is a mistake. It also has a nickname of investigation negative encephalopathy because most of the time the investigative results are negative. For example, neuroimaging findings are not helpful. The Mayo Clinic has a study done, and in it, around 79% of the patients have normal imaging results or have non-specific white matter abnormalities consistent with aging on the MRIs. If we look into CSF, and if we expect a classical inflammatory picture, it may not be present in many cases as well. So one clue that the patient may be having this, may be diagnosed with steroid responsive encephalopathy would be the high titers of antithyroid antibodies, in particular antithyroid peroxidase. So different guidelines have different cutoffs. Some guidelines suggest that the anti-TPO should be higher than 200 units to qualify for the patient to qualify as having steroid responsive encephalopathy associated with autoimmune thyroiditis. But many research has shown that as long as the antithyroid antibody level is high, it is enough, because higher titers are not correlated with more severe disease. So you may ask, what's the relationship between Hashimoto thyroiditis and the encephalopathy? And the answer is we don't know. The current research, what we know is that it's not the antithyroid antibodies that is causing the encephalopathy. It is an inflammatory process, but we are still doing research in finding out what is causing the encephalopathy. One recent study made this comment. Current pre-treatment criteria of the HG do not predict steroid responsiveness. The detection of TPO antibody across all control groups revealed their poor disease specificity. So what I'm trying to say here is that although when we are at the end of our ropes in dealing with patients with encephalopathy, like we have ruled out all causes, and it does not and the patients also does not present with a classical picture of autoimmune encephalitis, we may consider this diagnosis. We do not actually need to rely on the antithyroid antibody titer to make such a diagnosis, because this antibody is found in many normal subjects as well, and it does not predict the treatment efficacy. So what we did afterwards was we put the patient on a trial of Methylprednisolone, a 2-week course of Methylprednisolone. So the symptoms improved as soon as the 3rd day, and the patient became symptom-free by the 7th day. However, the symptoms relapsed when the steroids was tapered off. So, in fact, I'd like to point out that regardless of this, if this is a case of steroid responsive encephalopathy, or this being just a normal case of autoimmune encephalitis, most autoimmune encephalitis are steroid responsive. So the guidelines suggest that we do not delay the treatment for delay steroid treatment for antibody characterization, because this is an empirical therapy and it provides very rapid symptom relief of symptoms, and it is also associated with better long-term outcomes. So as the patient's symptoms relapsed, we also gave her 3 more courses of Methylprednisolone, and afterwards the symptoms did remit. However, the patient then enjoyed a symptom-free period of 18 months until June of 2021 this year. And when they relapse, the symptoms this time round are milder. She's only presenting with hand tremors and slurred speech. But after putting her on 3 courses of steroids, the symptoms did not fully they did not fully disappear. So what we are now planning to do is to start her on IVIG first. An alternative treatment will be plasmapheresis, and actually we can be very liberal to choose between which one to try first, because there's no convincing evidence of either approach being more superior. And in case both second line treatments fail, we will also consider cyclophosphamide. But it is also useful to tell the patient and that in many cases a return to premorbid status, functional status is not possible. So there are around 200 cases of steroid responsive encephalopathy recorded in literature, and there are 2 distinct clinical causes that have been described. So for young patients, the disease is more likely to follow a relapsing and remitting course, but they are also more likely to respond to immunosuppressive treatment. But for older patients, the disease is more likely to be progressive, and it's going to worsen indefinitely. And they also have a higher rate of being treatment non-responsive. So today, the take-home message is the first thing is for subacute encephalopathy. The most important thing is a full history, so we can rule out a lot of differential diagnosis first off. And then for workup, after excluding infectious causes, the 2 most likely causes will be autoimmune or inflammatory disease, and we will work on that by lumbar puncture and MRI scans. And for autoimmune encephalitis, we'll just treat it empirically first, and we do not wait for any specific antibody test results. I would also like to talk very briefly about autoimmune encephalitis. So the clinical presentation is very diverse. So it may manifest as a limbic encephalitis, so it may be presenting with memory problems or even psychiatric problems, or it may be a brainstem encephalitis, presenting with cerebellar ataxia and other brainstem problems Some cases may also be encephalomyelitis, which is rarer, but the take-home message is that autoimmune encephalitis has a very diverse presentation. And although some antibody-associated syndromes such as the anti-WHO encephalomyelitis, anti-MA2 associated encephalitis, and anti-CLMP5 encephalitis has been described, they are very specific and they are not very clinically useful when we are trying to make a diagnosis when we see a patient with encephalopathy. So the recommendations would be to take a full history and also to work up step by step to exhaust all the differential diagnosis possibilities and to come up with a diagnosis. And this is the end of my presentation. Thank you very much.
You know the code